So before we dive into a discussion today, I want to recognize the Algonquin Anishinaabe peoples, the traditional guardians of the land, where the Office of Results Canada is in Ottawa. We recognize their enduring relationship with this territory, which remains unceded, and we express our deepest gratitude for their stewardship. And at Canada, we are acutely aware of the systemic inequities rooted in historical injustices. And we all share the responsibility to remember the dispossession of Indigenous lands and to actively seek ways to demonstrate our solidarity with Indigenous peoples. This is also a moment for us to not just acknowledge the land and its people, but also reaffirm our responsibility to ensure that our advancements in health and innovations benefit everyone, leaving no one behind. In aligning our efforts with the Sustainable Development Goals, we should and must commit to fostering equitable partnerships that prioritize the health and rights of all, particularly those who've been historically marginalized and overlooked. So today we are centering our discussion on research and development in women's health because historically science and medicine have often overlooked the distinct health needs of women, especially in low and middle income countries. And despite some progress, women's health remains severely underfunded compared to its burden. And this reality was starkly highlighted by COVID-19. And women, many of whom are service frontline workers, faced heightened vulnerabilities and disruptions to essential health services. And this is not just during COVID, but we see it during our ongoing battles against infectious diseases like tuberculosis and beyond. With the deadline for the Sustainable Development Goals just 5 years away and the world already preparing for future infectious disease threats, it's critical now more than ever to increase investments in R&D that centers women's health. And global partnerships like the Coalition for Epidemic Preparedness Innovations, FIND, UNITAID, along with other initiatives like Gavi and the Global Fund, have been like tirelessly working to ensure that women's health and equity are key considerations in global health. And this is across vaccines, diagnostics, and treatment. And all these organizations work individually and in partnership with each other to ensure these life-saving products are accessible to communities where the need is the greatest. And I'm also like proud to say that Canada has been a leader in the space, contributing significantly to global health initiatives while also fostering research excellence here at home. And I'm thrilled to see a lot of those folks who made this happen on the call today. And our interests, investments, and leadership have led to life-saving innovations and improved health outcomes, especially in marginalized communities. Canada, for example, was among the leading contributors to Access to COVID-19 Accelerator, or ACT-A, while supporting organizations like CEPI, UNITAID, FIND, Gavi, and the Global Fund. All that said, we all know there's still work to be done, especially with multiple challenges the world is facing today, including climate change, current infectious diseases, and emerging pandemic threats. In terms of structure, we'll start with some opening remarks from Jean-Bernard Parenteau, the Director General of Global Health and Food Systems Bureau at Global Affairs Canada, and Dr. Genevieve Tanguay, the Vice Chief Science Officer of Canada. And then we'll open it to the panel discussion. And before I hand it over, I just want to note that there will be time for Q&A at the end. But if you have any questions for our panelists, please do feel free to post it in the chat and we'll get to these in the end. And we would really appreciate it if you all muted your microphones unless you wish to speak, in which case, please click the raise hand function. With this, I am thrilled to hand it over to Jean-Bernard Parenteau to speak to Canada's leadership in the global health R&D space, especially in relation to women's health and pandemic preparedness. So over to you, Jean-Bernard.
Thanks a lot. Thank you for setting the stage for the discussion today. Really delighted to be here virtually to be with you. So thanks to Results Canada colleague. Thank you, Taryn, for organizing such a discussion. When I look at the focus of the roundtable, so efforts to ensure that women's health and equity are key considerations within global health R&D, I can confirm that this is of significant interest to Global Affairs Canada. It's quite clear that research and development for new diagnostics, vaccines, and treatment are needed to help us tackle longstanding global health needs, as well as emerging threats. We also know that specific approaches are needed to ensure these innovations reach the people who need them most. There's vast numbers of women, children, adolescents, key populations that still face significant inequalities and barriers that prevent them from getting the quality health services they need to survive and to thrive. Canada is proud to have made a 10-year commitment to global health and rights as part of the Feminist International Assistance Policy, with a particular focus on promoting sexual and reproductive health and rights. So within this 10-year commitment, we are supporting targeted investments, partnerships, innovation and advocacy efforts with the greatest potential to close gender gaps in health systems and ensure respect for and fulfillment of everyone's basic human rights and access to care. We're quite proud of the partnerships we have with CEPI, FINE, and UNITAID. They're all addressing vital missing pieces of the global health landscape that are saving lives of women and girls. So through our partnership with UNITAID, throughout the COVID-19 pandemic and beyond, we've worked to increase the supply of medical oxygen in key countries by bolstering national oxygen systems and adopting new innovative models for delivering oxygen to the people who need it most. We also collaborate in the context of the partnership with the Global Fund to fight AIDS, TB, and malaria. We know as well that women require more diagnostic tests throughout their lives, particularly during pregnancy and childbirth. So we are grateful for the work being done by colleagues at FIND to improve access to diagnostic testing for women and girls. And finally, we're quite proud as well to continue partnering with CEPI to support innovations in vaccine development and manufacturing that enable access to those who need them most, including women and girls. The investments they have made in supporting clinical trials in pregnant women and in children are vital in accessing gaps in access to life-saving vaccines. Finally, I wanted to highlight how pleased I am to see these key global health R&D partners gathering together to discuss how to advance a collective objective within the global health space. Coherence and collaboration are the art of the Lusaka agenda and are critical to supporting a fit-for-purpose global health ecosystem. Some of you may know Canada has played an active role in helping to shape and advance the commitments outlined in the Lusaka agenda. We certainly strongly believe in the importance of global health initiatives working more closely together to support country priorities. So we look forward to hearing more about how CEPI, FINE, and UNITAID and others are taking forward these commitments within the R&D space and how they are collaborating further together. So thank you for having me today. Looking forward to hearing the remarks and discussions today. Thanks.
Thank you. Thank you so much, Jean-Bernard, for really setting the stage for this discussion. And at Results, we work across various GHIs, and I agree there's just so much power in all of us working together at multiple levels. And I'm so happy to see Canada really champion this synergy while also centering the realities of marginalized communities. And we hope to see Canada continue playing a leading role in this place, not just as a key donor, but as an ally to a lot of these communities and health initiatives. With this, I'm going to hand it over to Dr. Tangwe, Canada's Vice Chief Science Officer, to provide us an overview of how Canada works in the domestic R&D space to advance the health of people, not just in Canada, but also progressing health and equity of populations worldwide. Again, focus on the topic of discussion today, which is women's health and PPP. So over to you, Dr. Tangwe.
Merci beaucoup. Thank you very much for the invitation to speak here today. Women's health is an issue that is very important to me and to the Chief Science Advisor, Dr. Mona Nimmer, who, as you may know, is a health researcher herself. So I'm delighted to have the opportunity to contribute some thoughts to this discussion. Inequities continue to exist between men and women in most aspects of societies, and these inequities only deepen when we consider intersecting factors like ethnicity and economic status. This is certainly the reality in the scientific arena. In my current role, as well as in my previous role at the NRC, it has always been one of my top priorities to help advance efforts to support and promote women in science and research. One of the initiatives I've been most proud of to champion is the annual Women in STEM Symposium in February, which highlights the vital contribution of women and other underrepresented groups in advancing research and finding solutions to some of today's most pressing challenges like health emergencies and climate change. Why am I talking about women in science? Well, that's because, of course, the historical and ongoing underrepresentation of women in science has direct consequences to the women's health gap. Consider the fact that female researchers are more likely than their male counterparts to study women and to report findings by sex and gender, and that women biomedical inventions are more likely than men inventions to focus on women's health. This means that women participation as drivers and leaders in research and innovation is critical for improving women's health. Moreover, we know that women are not just underrepresented as doers of research. It's well documented that women have been missing as research subjects as well. It's been at least 2 decades since we have understood that the historical exclusion of women from clinical studies has severely undermined our knowledge of how women's bodies function and how they interact with disease and medication. Today, we're still playing catch up, especially when it comes to the inclusion of women of color and Indigenous women in clinical research. Taken together with the chronic underfunding of women's health research, it's no surprise that the women's health gap continues to persist. This is really quite incredible when we think about it, because women's health is hardly a niche market. Let's take, for example, endometriosis. This is a condition that causes debilitating pain and infertility, but we don't know much about its underlying physiology and can't offer much in terms of treatment. Yet, endometriosis is estimated to affect 1 in 10 women worldwide. That is 400 million women. And these health disparities are always exacerbated by pressure like natural disasters and emergencies. And we certainly saw this play out worldwide during COVID-19 pandemic. Women were disproportionately impacted by COVID-19 because they were more likely to be frontline workers and caregivers. These impacts extended to economic insecurity due to work interruptions and increased incidence of domestic violence during stay-at-home orders. And we are now learning more and more about the disproportionate burden of long COVID in women. All of this reaffirms the urgent need for strategic, collaborative, multidisciplinary efforts to close a global gap in women's health, particularly in the context of pandemic prevention, preparedness, and response. Certainly, the need to prioritize support for groups most impacted by health emergencies has been top of mind here in Canada. The recent published Walport report, which reviewed our federal approach to pandemic science advice and research coordination, specifically recommended that Canada increase investments in research on the actions needed to address the underlying health needs of disproportionately at-risk groups and communities. Similarly, our office published 2 reports on long COVID, both of which highlighted the importance of prioritizing research on the impact of this condition on women and in marginalized population groups. On the international stage, Canada's Centre for Research on Pandemic Preparedness and Health Emergencies is a founding member of the Global Research Collaboration for Infectious Disease Preparedness, which is a worldwide network of research funders that facilitates coordinated investments to improve preparedness and a rapid research response to pandemic. Furthermore, Canada has been a key endorser and supporter of the 100 Days Mission, a global effort with the ambitious goal of developing and making available diagnostics, therapeutics, and vaccines within the first 100 days after a pandemic's threat is identified. The Chief Science Advisor in particular has been a champion for this initiative and currently serves as chair of their steering group. While the 100 days mission goal of mitigating the overall impact of pandemics is important for everyone, it is crucial for women who are really disproportionately at risk. Particularly important for women is the rapid and wide availability of effective over-the-counter diagnostics. As primary caregiver in their households, women can play a key role in disease prevention, and they can make informed decisions with the help of diagnostics. This is an area that requires much more resources and attention, especially in low-income countries. Beyond the realm of health emergencies, the Government of Canada has been committed to using gender-based analysis plus in its development of policies, programs, and legislation for the past 3 decades. This includes a requirement for all federally funded health research projects to integrate sex and gender considerations into their research design and practices so that we no longer systematically neglect women's experience and need. Canada's Feminist International Assistance Policy has supported sexual and reproductive health and rights as one of its key objectives. These examples, together with other efforts, including some in collaboration with the organizations represented by today's panelists, CEPI, FIND, and Unitate, demonstrate our commitment to improving women's health, both in Canada and worldwide. But there's, of course, much more work to be done, and I'm grateful for the leadership of all those around the table today. Let us continue to have these important conversations and work together to put words into action because closing the gap in women's health globally is all of our responsibilities. Thank you, and I look forward to the discussions by our excellent panelists.
Thank you so much for that, Dr. Thangwe. I love how you really highlighted the importance of having women in science to advance women's health, and for also making that connection between the work we do here at home to support, to provide support to communities worldwide. And we hope to see these partnerships between departments and agencies continue to make a difference, especially in ensuring innovations reach communities where the need is the most. And we also hope to see more women in science. So thank you so much for those remarks, Dr. Thangwe. With this, we'll dive right into the panel discussion. I'm absolutely thrilled to introduce our panel today. We were expecting, and we still are expecting, Carol Navina to join us. Again, like I mentioned, she's based in Zambia, and Zambia is just going through its worst drought in the last 2 decades. So they're having like drought-related power outages, but she's still trying to get connected. But she's a TB HIV activist from CITAM Plus that advocates for treatment, care, and support for people infected and affected by TB and HIV/AIDS, malaria, and infectious diseases. And CITAM is a part of the Action Global Health Partnership, which Results is also a part of. And given her years of advocacy, it's no surprise that Carol serves on various global health boards, including the Global Fund and Stop TB Partnership. So hopefully she can join us in a bit. But we also have Angela Muruyuki, the Director of Women's Health Program at FIND, who's currently visiting Ottawa. We have Smilka De Lucini, Program Manager from Unitate, and Valentina Bernasconi, Head of Laboratory Science at CEPI. And in the interest of time, I'm not going to introduce these organizations or the work they do, because the speakers will introduce their organizations and the work during the course of their interventions. So to kick off a discussion, I'd like to pose a question to all the panelists. And the question is, how does your organization prioritize health equity, gender, and locally driven solutions in your work? And all your organizations receive funding from Canada. So it would be super helpful for you to provide concrete examples of the impact of Canadian investments in advancing these areas. So we'll probably start with Smilka.
Thank you so much. And I hope you hear me well. And bonjour and good morning, actually, in Canada. This is really an excellent opportunity to discuss some of these pertinent topics. And me being a woman active in public health, I will just expand not only in science but also in public health. We do need more voices, so it's really a pleasure always being in this type of fora when we can both appreciate the impact of different policies, but also appreciate how small adjustments to how we work can actually make huge differences in the field. I will start maybe with, as you suggested, as just to say that, first of all, when we were founded in 2006, it was because some of the key issues in the how we looked at, especially in the HIV, TB, and malaria, how we looked at both children and also women issues, and women's needs were addressed or not addressed. The kind of the foundational DNA of UNITAID is especially looking into those underserved populations. In 2006, our first major investment was about creating the pediatric market for HIV medicines, which also impacted on how we looked at pregnant women and also women who deliver. Following that, we made sure that each of our investments actually had as it was mentioned before, had that understanding of how we can improve the data, as well as tailored approach for pregnant women or those of childbearing age. And it's really important, and I will discuss that a little bit later as well, that childbearing age is a very large kind of year-wise span, and that we are really kind of looking into that as well, on how at each stage of life women's needs change and grow or change in characteristics. Then another thing that is really important is that unlike maybe some other interventions, our interventions are trying to cross that gap between when we research and develop the product to actually having it at scale introduced in countries. And this is where we have not only R&D in our focus, but also really improving the access. So access from the point of view of not only the pricing, because we usually talk only about the prices, but really understanding what delivery models for health products. So as we are talking about invention and coming up with new ideas and new products, UNITAID is really focused on innovation, which is on how those products can be put into practice in countries. And then thirdly, I want to say that the important element is that we really pay a lot of attention to listen and meaningfully engage. And this is really important from how our governance is structured and having communities and civil society, but especially community voices in our highest decision-making bodies, but also really looking at how we can, at the level of implementation, so at that healthcare facility level or the village level, have the input of women in what their choice and preference is, to also having advisory boards and other functions established for each of our investments to actually inform it. So maybe those three kind of core items around UNITAID more generally. And I don't know whether you want me right now to address the second question about Canada. I mean, it was already mentioned before about the collaboration that we had directly, and I wanted maybe to zoom into that on the oxygen partnership we had with Canada during COVID. And I had the pleasure and honor actually to go to Rwanda and visit one of the hospitals that actually had an opportunity to benefit from that. And I think one thing is when we design the interventions, they are usually designed around the specific issue, which was in this case the access to oxygen. But it was very interesting to observe how that small intervention in the context of PPPR actually made a huge difference for mothers and children who came to that hospital for different issues and not only COVID-related issues. So the funding, and this is what we always try to do at Unitaid, is to think about also kind of other health needs that might be impacted with what we fund, and not really zooming only on a specific health condition. And I want to, we will talk a little bit more about like our recommendations towards Canada in terms of the policies, but I really want to say that for us, generally seeing in this world where we are seeing an increasing backlash against women's health needs and rights, the fact that Canada is really right front and center promoting the feminist international assistance policy and continues to prioritize and ensure women's health needs are not neglected makes a lot of difference, both to us, but also to the organizations that we work with in the field. Thank you.
Thanks so much, Melika. Angela, do you want to take that question?
Sure, thanks, Ekata. And again, echoing Dr. Tangwe and Smilka's words, this is a topic that is very, very dear to me, not just as an African woman and a physician, but a woman in science. So I'm really pleased to be here. So FIND's women's health work was birthed out of a grant that was given to us by the government of, by Global Affairs Canada for COVID. And this was also in recognition of the need to strengthen sex and gender work within diagnostics. So it started as wanting to build in sex and gender work, and then birth an entire women's health program that I lead. So currently all my work is actually GAC funded. And in thinking through this, I wanted to give two practical examples of how we've been able to address gender health equity and local solutions. So as within FIND, we've now developed a sex and gender framework that advances all of the work that we do. And one practical example that I really like out of this sex and gender framework, beyond integrating sex and gender operationally, but also technically around data disaggregation, ensuring that we're reporting outcomes for both sexes, is a framework that was developed by our gender lead with a group of experts that looks at key sex and gender questions across the entire diagnostic value chain. So at each step of the diagnostic value chain, that allows us to explore whether we are actually aiming for gender equality in product development. And these are questions that range from all the way upstream R&D. Are we looking at performance of diagnostics for both sexes? Are the biomarkers that we're looking at, particularly if it's not for a condition that's female specific, are they the right biomarkers for both sexes? Down to gender, looking at gender in local manufacturing, and are we looking at gender equitable policies in the local or the manufacturers that we work with, or gender equitable pay or gender exploitative practices, down to access strategies that reflect the gendered nature of access to and use of diagnostics. So for instance, what strategies, and Dr. Tangwe mentioned this in her intervention, that the fact that even putting diagnostics in the hands of women improves their decision-making power, not just for themselves and their bodily autonomy, but also for their households. And so in thinking through a gendered approach to product design as well, if you can get it in the hands of women or as close to home as possible for self-testing, for self-collection, then that becomes, if that's an option, then that's the option that strengthens gender and access. And the second way we've done this, so FIND for a long time has wanted to strengthen how we engage with communities, and in true partnership with how we engage communities, not just at the tail end of diagnostics, but throughout the diagnostics process. And so currently in our cervical cancer work, we catalyze the formation of our community coalition. So these are grassroots organizations across 16 countries, all of them small CBOs that have come together in a coalition. And the idea was to get the voices, the grassroots voices of women and girls in the diagnostic process. So in this case, in product drive through to access. And we've worked with this group around diagnostic literacy and getting them to understand complex diagnostic terminology and apply it in their advocacy and apply it engage them in the diagnostic value chain. So for instance, when WHO was released the target product profile for HPV tests, target product profiles tend to be very complex, very sciencey documents, but then they call for CSO engagement. And so in this case, we had to educate them on what it means, what a target profile, what are all these jargony things, and then how do they input properly or effectively into our TPP process. We've also worked with them around user-led research, trying to understand women's preferences in terms of self-collection, in terms of where they would want to receive services. So building the community capacity to do their own research and then inform service delivery mechanisms. And this is also an area we worked quite closely with SMILCA and the Unitaid folk around, because as they were also developing their CSO work for cervical cancer, rather than develop an entirely new structure, this is an area, because it's the same countries, it's the same focus. And we appreciate the fact that they work together with us to strengthen this platform and to give voice to these community advocates, because creating the platform that the community advocates can speak on a global level and give them the language and the platform that allows them to advocate for access to diagnostics for women, rather than the usual top-down advocacy that often happens. So this has been a powerful approach. And so this has started to form a lot of how we do our work. So now as we get into new areas of work like iron deficiency anemia and preeclampsia, I'm glad to hear Dr. Tangwe mention endometriosis. Is one of my favorite things to talk about right now. Starting to surface needs of women early on, so we understand what do they need and how can their needs feed into the prioritization and the product development process.
Thank you so much, Angela. Yeah, I mean, completely agree with you. There's just so much power in like engaging grassroots and pushing for like bottom to like top to advocacy. I'll hand it over to Valentina to respond to this question from CEPI's side.
Of course, thank you very much. And first of all, I'm really glad to be here today. This topic is very close to my heart, being a woman in science myself. And so equitable access to vaccine is really the heart of CEPI missions, and it drives everything we do and everything we fund. And our real central dogma is getting those vaccines to the population that need them the most, and ensuring also that nobody is left behind, no matter whether they're located or their demography or their ability to pay. And equitable access is also the center of the UNDRA mission that was mentioned before, which is shared not only by CEPI, but also by Unitaid and FIND. And it's an ambitious goal. It means that we want to deliver, at least for the CEPI side of it, we want to deliver vaccines and but also therapeutics and diagnostics within 100 days from the start of an epidemic. And this concept is also embraced by Canada and other G7 and G20 nations. So, the faster effective vaccines are developed and deployed, also the faster potential pandemic can be controlled and contained. And of course, gender balance and health equity considerations are very critical in our activities, and also they're consciously factored in our day-to-day work. And CEPI is really grateful to Canadian government for the investment in our work. And this has begun since CEPI's inception in 2017. So it has been a collaboration that lasted very long. And also for even highlighting the importance of health equity and gender equity, and the fact that this should be embraced in our day-to-day work. So we do think about it in an active way, both internally in our organization and also externally. And I just wanted to give you some examples, and I probably will talk about it more later on. But internally, You know, we really want to make sure that we have diverse gender and geographical representation in our leading bodies, such as, you know, our board, our scientific advisory committee, and also having a non-discriminatory policy when hiring collaborators and hiring our colleagues that will work with us in the future. We do have many initiatives, you know, at the global level that touch very many different countries, and we really try to put attention in gender balance when we have those R&D initiatives. Just out of curiosity, recently we have been, so our research and development team has been monitoring CEPI-funded publications and whether women were part of it as authors. And it just came out then, you know, from the launch of CEPI in 2017 to a few months ago, so to July 2024, about 92% of the publications that came out from CEPI funding resulted as at least one female author in it, with more than 40% where the female was the lead author in that publication. And I think it's interesting, and we will continue to track those efforts, especially not only related to women, but especially related to women in low middle income countries. And in terms of, you know, the work we fund, of course, we are very keen in funding clinical trials to monitor the efficacy and the effect of those vaccines when we deploy them in different populations. And we really pay attention on designing randomized clinical trials for novel vaccines that include different populations, because we really want to see the effect of those vaccines in as broader population as possible. We have been funding clinical trials involving pregnant women and also breastfeeding women. And those clinical trials are mostly carried out in endemic settings, so locally where there is the need of those vaccines to be deployed afterwards. And it's very important that we pay attention to use those local data or data in local populations to best inform us on about the effect of those vaccines in different populations. And an example could be the Ebola Janssen vaccine trial, which was carried out in more than 2,000 healthy pregnant women in Rwanda. So I think, yes, it's very important for us to take this broader perspective. And another example is, and maybe then I will stop there, but the work that we have funded for around COVID-19 pandemic, to provide scientists and the decision makers with more in-depth knowledge on how COVID-19 vaccine works, also or specifically in the most vulnerable populations. So in that case, we were looking at people living with HIV and also immunocompromised people, elderly, and of course, pregnant women. Because we really wanted to help expand the access to COVID-19 vaccines to a broader population as possible. So it's really, you know, in the heart of our daily work.
Thank you so much for that, Valentina. It's just so inspiring to see a lot more women researchers, like research being spearheaded by women, and we hope to see more such papers coming out from women. We'll go to the second question. This will be more directed at like specific organizations and the work we do. So basically, Angela, I'll start with you. FIND has been instrumental in developing diagnostics tools and has recently expanded its portfolio to include women's health. Where does like FIND right now see the main gaps in diagnostics for women and girls in low and middle income countries? And in what areas would like strategic investments and partnership, do you want like partnerships or like investments to narrow the diagnostic gap for women and girls?
It's such a weighty question because the diagnostic gap, particularly for women and girls in LMICs, is such a complex, multifaceted issue. And because it's a factor of having the right test at the right time for the right condition to achieve the right outcomes. And each of those pieces is an entire thesis on its own. So I'll just narrow down to one when we're talking about the right condition. And traditionally, when we talk about women's health, it is conflated with sexual reproductive health or maternal newborn health. But women's health is actually broader than sexual reproductive health or maternal and newborn health. I think everyone by now must have seen the report that the McKinsey Institute released this year's World Economic Forum, Closing the 1 Trillion Gap. And so they looked at the burden of disease. They used burden of disease data to examine what conditions were causing the most morbidity for women. So they found out that women spend 25% more time in ill health than men. And the primary drivers of this ill health or this morbidity, 5% of this was maternal or female-specific conditions, maternal health, or what is traditionally SRH. 51% were conditions that affect women differently or disproportionately. And this would be conditions such as sexually transmitted illnesses, anemias, chronic obstructive pulmonary disease, cardiovascular conditions. But these are the areas that are women's health, but not typically thought of as women's health because of we tend to think of women's health as sexual reproductive health. So the number one gap we see around diagnostics for women is a definition of women's health, and that needs a broader, more expanded definition. So we're thinking as women, not just in terms of their female specific or the maternal health or sexual reproductive health. Not saying that these are not important. I've spent my entire career on sexual reproductive health, but looking at applying a wider angle lens and thinking about a woman across her entire life cycle, because even as we reflect on a feminist approach, a narrow focus on sexual reproductive health leaves out the women who choose not to reproduce, who have finished reproduction or are unable to reproduce. And what this means then is, and one other thing that I found interesting about the data from the McKinsey Institute, the 5% that were female-specific conditions, well, when you look at LMIC data specifically, that goes just up to 8%. But it's still a bit of an underestimation because that's where the gynae conditions sit. But we know from clinical practice or from anecdotally from family and friends that conditions such as endometriosis, polycystic ovarian syndrome, infertility, and fibroids are such major issues in our contexts, but they do not appear in the data. And why? It's because we're not looking for them, because there are no diagnostics. Dr. Tangwe talked about endometriosis, which is an example I like to give. It takes about up to 10 years to get roughly 6 to 10 years to get a diagnosis for endometriosis, because they're not, and all of the diagnoses available today are invasive. So there's a lot of work that still needs to be done around addressing the diagnostic gap, even for female-specific conditions, but more particularly in line with where the morbidity is coming from. We know women present differently when they have cardiovascular diseases. So a heart attack appears differently in men than women. We're now learning that this is, we were trained using the male model of how cardiac diseases affect men. And so if I was to wave a magic wand at this particular issue here, I think one of the biggest areas that strategic investments or strategic would move the needle is starting to build the capacity of the global south to present, to develop high quality R&D. Because one of the things we know about the diagnostic gap in women is that it's not just a low income issue, it's an everyone issue right now. And the women's health R&D gap, therapeutics, vaccines, diagnostics, it's an everyone issue right now. And COVID taught us when it's an everyone issue, we get left behind. So rather than waiting for trickle down R&D from high income countries to be adapted to what we need in our context, it's important to start investing in the capacity of the global south of the LMICs to contribute high quality R&D in order to fill this gap, because this gap is so massive. It will not trickle down, will not do that effectively. But also importantly, why we need to invest in strengthening high quality R&D that fits the high level, the stringent regulatory authority standards from the global south, is that we have such a large genetic diversity within the global south. And so high quality R&D from the global south can only benefit everyone, because in this day and age of migration, in this day and age of moving more towards precision medicine, precision diagnostics, we need that level of diverse genetic pool to be able to build high quality diagnostics. And finally, investing in global south capacity is the right thing to do. It can only be beneficial for all of us.
Thank you so much for that, Anila. It was a super powerful intervention. I feel like there's an entire paper in there based on what you just said. I'll hand it over to Smilka. Smilka, like United works across portfolios in global health, but primarily in ensuring access to products, which I think is super important. I know you've been working on investing in adapting health products and the delivery for women of childbearing age and children. Can you share some examples of how these investments have improved access to essential medicines and tools for women, particularly in underserved regions?
Thanks for this. I wanted to choose two examples, one on medicines and the other one on diagnostics, because it kind of spans across what we usually fund. And there is an article that was actually an abstract that was released in 2019. For those of you who work in HIV, you know how groundbreaking the discovery and approval and adoption of dolutegravir has been for everybody who is on HIV treatment, and especially the kind of the switch from efavirenz, especially from the quality of life perspective. And there is an abstract that was published in 2019 by Pepperell, who analyzed what was throughout all the studies that were done on dolutegravir, how many actually Black females, as they call them in the abstract, have HIV and live with HIV in the world, and how many were actually included in the study. And 42% is the burden of HIV in Black women, and 3% only were in the studies. So that kind of discrepancy. And 76% of all the studies were done actually in high-income countries. So for us as UNITAID, taking that and understanding that we should do and protect women through research, not from research, is basically the starting principle of what we do. So we did fund a study that actually was based on the continent, in Africa, in Uganda and South Africa, that looked into DTG's value in preventing vertical transmission, so in pregnant women. And that was an important data that actually was very valuable for both informing the recommendations, but also informing the implementation. And then in 2018, WHO issued a safety warning about DTG, especially in women, which was around both weight gain, but also some instances of neural tube defects in newborns. And there was a lot of the dynamic around what to do with that safety warning. And what we did is actually to support a community dialogue with WHO, and it happened in Kigali, where we brought together 39 women from 18 countries who actually unanimously recommended to proceed with the recommendation, and so they were the ones to actually assess the risks and benefits of dolutegravir for different populations of women at different stages of their life cycle, and that kind of brought towards actually continuation of that recommendation. So it's both how you generate the data, but also how you listen to, sometimes the value put on different issues is different for a woman who is benefiting from that than for a researcher or a policymaker sitting here in Geneva. The other thing that I wanted to maybe bring as an example was our work in cervical cancer, and Angela addressed it a little bit, but when we started working in 2019, it was really about going away from pelvic exam into doing HPV testing for understanding the risk of cervical cancer. And one of the really interesting modality of doing the HPV testing was to do it through self-collection. It was really something that we believed in, and this is what we mean when we think about making diagnostics work for women. And all of us women, we know what it means to go to a gynecologist and get that exam, and to what extent that can be invasive, uncomfortable, culturally, religiously inappropriate. So the self-collection modality was really something that we invested a lot in. We tested it across different geographies. In some geographies, it was interesting to start off with women actually not wanting to do it because of the trust in healthcare provider more than in their own skill set to do the self-collection themselves. But also that was overcome with appropriate information about how you do it and anything related to both risk, but also related to the capability of a woman on doing it. It's a very empowering approach as well. So just to say that also we did recognize as well and said that not every country and every budget can actually afford HPV testing. So we knew that some women will still have to go through the visual examination, either with naked eye. And then we thought about how can we use AI in this context, and how can we actually support that if a woman still needs to have a visual pelvic exam for inspection for any lesions, how can we improve the accuracy, which is very low right now, around 40% sensitivity. And we are still working and investing in AI-based solutions that could read the images of cervix and actually help providers understand any risk. So maybe those two examples are the highlights of some of the issues that we've been discussing so far. Thank you.
Thank you so much for that, Smilka. I mean, especially through these examples, you've shown the importance of like culturally sensitive, locally, like basically diagnostics and tests that are like grounded in local realities. But thank you so much for that. Valentina, coming to you. I know like among all the GHIs, CEPI is known for its focus on heart science and especially in the development of vaccines against emerging viral threats. And given this focus, you've covered a bit of this already, but given this focus, how does CEPI ensure that women's health and gender considerations are prioritized in pandemic preparedness initiatives, for example, such as the 100 Days mission? How exactly does CEPI integrate these considerations into R&D efforts to ensure vaccine development benefits women from low and middle income countries? And again, like I said, among all the GHI, CEPI's focus is on heart side. So I know it's like slightly trickier to like demonstrate more clearly like the connection between gender and science. But over to you, Valentina.
Thanks for that question. And really, CEPI does view gender balance and health equity as an important part of the 100-day mission. But also, achieving equitable access to vaccine means that we need to think about health equity and gender balance. Also because, women are, as was mentioned before, are often at the front and center in different health services delivery. And at the frontline care, they are frontline care workers in community and hospital settings. And when we talk about pandemics and epidemics, that's what we're talking about. And they are put more at risk of exposure, of course, when it comes to new epidemic and pandemic threats. And also pregnant women are at high risk for adverse pregnancy outcomes if they are infected with some of those viruses that we deal with. So some examples of how CEPI has implemented gender perspective in its activities include, of course, funding women scientists and trials that aim to expand access to vaccines for pregnant and breastfeeding women. So I was mentioning some of those trials that we funded for both COVID-19 and for Ebola in health pregnant women. And we're also planning to fund more pregnant women vaccine trials in the future. Those are not publicly, kind of said yet, but just hold on, and we will announce those soon. And also the importance of designing randomized clinical trials for novel vaccine that do include the recruitment and enrollment of different population, including women. And what was said before about the percentage of Black women with that are living with HIV that were included in that study, it really struck me, because how can you be including everybody if you then end up with such results? And of course, we do see challenges when we do our day-to-day work and we think about gender balance, including, for example, when you look at emerging pandemic threats, they do impact women more than men, and that was said before as well. And when we also think about our grants funding, the application that we receive are typically male-driven. So this is something that we want to look at also in the future. And some things that we really want to think about in the future, and that was, I'm glad that Angela mentioned that before, is really community engagement and capacity building in low middle income countries. We really need to start from there in order to build a more gender equity in health, and make gender balance and this equity message come out in public, and make sure that people know that this is important for us, and other initiatives should kind of gather together and follow the message as well. There should be strong and strengthened collaboration and coherence and alignment on this message moving forward. So we're really looking forward to collaborate with all of you on that.
Thanks so much for that, Valentina. I mean, there's just so much power just on this call to like make that noise that we need to. But moving on to the second question, as Angela outlined, there are several barriers for women in accessing health products. I know all three of your organizations work with global partners like Gavi, Global Funds, Stop TB Partnership, and others. So I just want to find out like how your organizations work with each other and with other global health initiatives to overcome barriers to healthcare, especially for women. So Valentina, do you want to start first, and then we'll...
Yes, and I think this links also to what I was mentioning before. So first of all, working with local organization on the ground and making sure that they own and lead the work is really a key, and collaborating with all those international organizations like FIND and UNITAID and Gavi and so on really helps us in that. Community engagement is very important, and we work a lot with capacity building in low middle income countries. For example, something that is really related to my day-to-day work is capacity building for laboratory activities, but we'd also do capacity building for manufacturing of those vaccines that has to happen, in low middle income countries and in the areas where those diseases are endemic. And also capacity building for clinical trials to be able to run those clinical trials in the areas where then the disease is really a burden. And we are, under suggestion of Government of Canada, actually, we are developing a gender policy at CEPI as well, to be able to work on that internally. And one thing that we like to do as well is to be able to advocate for women in science, and follow up on campaigns such as the International Women's Day, and Girls in Science. So we have a lot of initiative internally on that, but also trying to inspire more girls and more women to take up science roles, because it's passion, and this can start from childhood. So I think really working together, all those bigger initiatives and bigger organizations to make gender balance and the equality message coming out strong is really the key.
Thanks, Valentina. Angela?
Thanks. And Valentina, I'd love to talk to you more about community engagement in the science. I have a patch of gray hair here that's attributed to community engagement. It's not as easy as it sounds. But coming back to how we work together. So one of the most challenging things about working in women's health diagnostics is that diagnostics are not central in the care of women's health, because normally we have perfected the art of syndromic management or symptomatic management, or so in the sense of offering a diagnostic is not the routine, or blanket supplementation and what have you. So offering a diagnostic is not the routine. And so like Valentina said, a core component is first community engagement, because once you start listening to women and what is important to them, when you hear issues around women's pain or women's issues like abnormal uterine bleeding, those are things that are treated symptomatically, but then you have to start thinking about a role of a diagnostic. But then also a second way is, and Smilka, who's not just a work colleague, is a dear friend as well, in working in cervical cancer diagnostics is a slog, because there's an imbalanced emphasis when you look at the 3 pillars on vaccination, but not as, which is a critical component. But then there are some of us who are past the vaccines age, and we find ourselves in meetings often saying, look, vaccination is critical, so our children never have to deal with this, but we're still here. We missed the vaccine, and this is where diagnostics matter for us. And so the kind of partnerships that allow us to leverage off of each other, partnerships with folk like at the WHO, where we say, now it's necessary to put in a diagnostic in a clinical algorithm. It's not enough to say syndromic management of STIs. This is an algorithm, and this is where the diagnostic comes in, because then we start to make diagnostics central. Now, the study I mentioned from the McKinsey Institute, one of the findings that they, on the age where this burden of disease was greatest, the peak was actually 40 to 60. So one of the more neglected ages in terms of women's health by LMIC health systems. And these are the ages where diagnostic matter critically, because the conditions that are causing morbidity in these ages are largely uncommunicable diseases, your diabetes, your hypertension, your cancers. And again, this is where early detection matters, because the later you catch it, the more expensive it is to manage and the harder it is for outcomes. And so, and learning from our pandemic preparedness colleagues, this is what our surveillance should be looking like, trying to catch these diseases much earlier and intervening, so that by the time a woman is getting into her 30s, she already knows what she should be screening for. But it starts with centering diagnostics, and then ensuring that these diagnostics are available, and then working together to make sure diagnostics are as critical as the therapeutics and the vaccines.
Thanks, Angela. Smilka, do you want to go on working with other GHIs and working with each other?
Yeah, quick couple of examples. I just want to highlight maybe a couple of things. First one is the power of what Angela was saying when Science started to work on creating the African Cervical Health Alliance. And I love that it's focused around health and not cancer. And it kind of shifted the whole dialogue about the cervical cancer. We came in and we said, it is really important to kind of have both the visibility of that, but also to see this as a platform that should be sustained, should be supported. Each of us as donors and as partners have different flexibilities and different approaches to funding that might strengthen the core capacities of these kind of platforms. And this is what we wanted to build on and not do anything parallel or new. And very important, I mean, to Valentina's point, there are, HIV community especially has been super successful in creating community advisory boards that sit on DSMB boards and review the data, advise the research design, and those are existing, especially, and topical, and we are having them more and more. So these kind of models that we can share, support together, and nurture especially are important. The second example I wanted to make is our current collaboration with Gavi. We have started working with them, recognizing that Gavi works in primary prevention of cervical cancer. We work in secondary, and saying, okay, which are the countries where, together with national programs, we can design integrated approaches to marry the kind of the approach between targeting girls and targeting their mothers in providing them the cervical cancer care. So we hope to soon announce a partnership in 2 countries that is actually based on this approach. And then the third one, maybe just very quickly, in 2017, this is again a diagnostics example, but in 2017, when we recognized that HIV could be diagnosed in babies at point of care, but with the new small platforms, there was a lot of resistance for some of the stakeholders that have done large investments in laboratory capacity. And there was that kind of a little bit of a tension between how do you build a laboratory based off of centralized platforms, but then introduce point of care. And we had to sit with PEPFAR, especially in Global Fund, together and say, how this is really a game changer especially for pregnant women, where you need to know the viral load status very often and very timely in order to adjust the treatment, but also to the babies. So that kind of platform building where you can meet with donors, meet with countries, and understand. Today we have an integrated diagnostic consortium that not only talks about these platforms, but every disease area, every diagnostic area, and how we can align is very important. So, and at the point of the technology being even imagined and in the research stage, and not only when it shows on the ground, I think that's an important also message on how to align the best. Thanks.
Thank you so much, Smelka. And with this, we come to like the final question, like closing remarks from all of you. And if you can like quickly say, like, I know it's hard, like given how much we've covered, but what specific commitments, whether financial, policy driven, or through partnerships, can Canada make to accelerate progress in advancing women's health and ensuring equitable access to vaccines, diagnostics, and treatments, especially in the context of a global pandemic, for example? Angela, do you want to start?
Sure. So I have 3 asks. One is for Canada to continue to be, going to what Smelka said, a leader in women's health, and especially in these times when women's rights are being rolled back, but also with a wider angle lens, understanding that women's health is beyond sexual and reproductive health. 2, the investments in R&D in the global south, because like I said, it can only benefit us all. And 3, a commitment to continue to invest in CCSOs and building CCSO capacity. That requires a level of flexible funding that most donors do not have, because when you commit to listen to communities, you can't listen to them in the lens that you want to listen to them. True partnership requires a level of flexibility that very few donors have. So those are my 3 asks.
Thanks so much for that, Angela. Smelka, do you want to go next?
Yeah, and Angela covered the policy one. It's really one thing that when I think about Canada, that's the first thing that I think about. It has been always the leader in that sense. I wanted to maybe shift to one piece which is close to my heart, just from the perspective of how achievable it is, which is the elimination of cervical cancer by 2030. And especially because Canada has been such a major investor in cervical cancer via HPV vaccination, that really kind of shifting and saying we do need, for the elimination to be successful, we do need a concerted effort, both in vaccination, but also thinking about, as Angela said, women of our age who cannot benefit or will not benefit from vaccines. And thinking about that screening and treatment and investing in those programs, we are seeing an enormous momentum this year, especially with a few countries coming out and saying we are going to eliminate. Rwanda is just considering announcing that elimination agenda even in advance of 2030. So we have a unique historical opportunity to eliminate one NCD, one cancer, within our lifetime. But that cannot be done only with vaccination. And I have been looking at some data from India that really speaks that in the next 50 years, the biggest number of lives or deaths averted is going to be from screening, not from vaccination, just because on how the progression of cervical cancer goes. And we've been looking at the British Columbia. British Columbia has always been such a champion in Canada, especially in the HIV and harm reduction space, but also now looking at how they look at the screening. They have been championing especially the self-collection approach, which is close to our hearts. And seeing some of the modeling of British Columbia saying that if they're going to eliminate cervical cancer in British Columbia by 2034, which is achievable, they will need to double down on the screening. So just to say, maybe the major ask is let's eliminate cervical cancer together. We can do it, and let's do it in a kind of a comprehensive way. Thanks.
Thanks, Smelka. Valentina?
Thanks. I think, we really see Canada as a leader in ensuring that gender equality footprint is really high on the agenda at the global level. And is really a front runner in this space. So we really think that many countries should learn from Canada in this. But if I need to get down to some asks, I think I have two, based also on the conversation that we have today. And the work that we are doing on a day-to-day basis. So the first one would be really to continue the investment, so the funding to vaccine development and deployment of vaccines to low middle income countries, in order to prevent pandemic threats, which do affect women in a very hard way. And the second thing would be to continuing champion the importance of women's health and also women in health.
Thank you so much for that, Valentina. And if you have any questions, please feel free to post them in chat or raise your hand here and then I'll come to you. Oh, yes, Robin, go for it.
Hi, everyone. Really great to be here with you. I'm very, very proud of the fact that my country is helping to move and support the likes of FINE to increasingly prioritize women's health. I'm so proud of that. And I know that from the work Canada is doing with the Global Fund and Stop TB Partnership, we're also championing meaningful community engagement. And I'm just curious, what's being done by Canada and also the partners here today to capture those experiences and share them with others so that people aren't reinventing the wheel in terms of changing policies, updating their M&E frameworks, working through challenges, etc. So what is being done for that? And then how are you disseminating that right now? And if you aren't doing that yet, I have tons of ideas, so would love to share. And then another question would be, how are the two teams from Canada, so Dr. Tonge, your team, and Pierre's team, working together to fund and support the partners that are here today? And lastly, just to flag that notably Canada is not yet investing in the TB Alliance, which is doing really important work to discover, develop, and deliver new treatments for TB, the leading infectious disease killer in the world. So I'd love to have the opportunity to share more about their work, who I work with as a consultant, so that we might be able to increase our investment and fill a gap in that area that's currently missing in our portfolio.
Thanks, Robin. Does anyone want to take the question? Especially one on how do you disseminate messaging or the impact of Canadian investments, how Dr. Tangue's office works with GAC to support these initiatives.
Maybe I could start with a quick comment, and I think
Sure.
I would like to take on the Robin's suggestion to help us in doing that better, and I bet that our communication team will love to engage with you on that. But I think for us, it's scientific publications is really the key of our work, and also press releases and being part of this of such a panel is really important for us. So thanks for organizing. And Robin, I think I need to connect you with our comms.
Thanks, Valentina. Dr. Tangue?
Yes, we work with GAC on many things. I'm not completely aware about that file, how we work together. Carrie just came on the screen, so maybe she will help me. We will have a departmental science advisor also with GAC. It's not announced yet officially, but I know that talks are going on so that we have a better connectivity with what's happening at GAC. It's important that we keep these initiatives, and as you say, that we work together. Now, the Office of the Chief Science Advisor advises, doesn't have money, doesn't put programs together and everything. So we're greatly dependent on our colleagues from departments and agencies to do the work that we would like Canada to be involved with. So Carrie?
Yeah, thanks so much. And thanks so much for this session. Robin, thanks for the question. Yeah, in terms of your query about how Canada really is kind of publicizing or profiling our investments in terms of R&D and innovation and the support to the partners, of course, that have been speaking here about this in terms of women's health. I think the report that we provide annually on the 10-year commitment to global health and rights that Jean-Bernard had referenced in his remarks at the start of the session is one of the key means by which we do provide specific examples and lessons learned in this area. So yeah, I would encourage folks to look at that. It's published online, and we have a session annually to profile that 10-year commitment report. Thanks.
Thanks, Carrie. We have like time to take like 1 or 2 more questions before I hand it to Dominique.
Yes, thank you, Ita. So my question is, well, first of all, this was so informative. I have to say thank you. It was really fascinating and very energizing, so thank you all. My question is related to the Lusaka agenda. So Jean-Bernard mentioned this in his remarks, and you certainly highlighted some areas of alignment among your organizations and a shared commitment to equity. This leads me to ask you, how are your agencies incorporating the principles of the Lusaka agenda in your work, and especially around integrated service delivery and support for primary health care? Thank you.
Thanks, Ram. Does anyone want to take this question? On the Lusaka agenda, and how do you like push for integrated care, especially at the primary healthcare level?
I can go first. So primary healthcare, I mean, diagnostics and primary healthcare is core and central to what we do. And actually, our priority in terms of how we work on diagnostics, and particularly for women and girls, is how can we get diagnostics as close to home as possible? And so either at primary healthcare community level or putting them in the hands of women. And so it's a core part of our strategy. And then with women's health, because often access to care is a challenge for women. So when you get them at a facility or when you get them at home, then applying that lens of integrated care. So this is why it's not advisable to do individual disease programming, particularly when it comes to women's health. And the beauty about a population group, because you can think more holistically, meaning then that because given the challenges of access to care, that one contact you have needs to be maximized. So then the ability to think through, for instance, if I have a 40-year-old in front of me, then I need to know head to toe what I need to do with them. I need to be screening for NCDs and STIs and everything else, and not just the one thing that traditionally vertical programming tends to do. The beauty about a population group is that you need to think more horizontally.
Thanks, Angela. Does anyone else want to take this question?
Yeah, maybe if I can, if I may, just a couple of thoughts on that, because when we started working, even just with FIND, we are currently thinking through multiplex diagnostics and what does that mean? And what do you put in a multiplex diagnostics from the perspective of what is the most interesting, applicable, and impactful at the primary healthcare level? This is where that kind of integration comes into play, especially from the perspective of even the geographical needs. You know, a woman in Latin America will have different needs than in Africa or in Asia. So thinking through those things. But one of the other issues that even naturally made us think about integration is that the financing is short and of anywhere where we would like to see it. So when you think about even when we started implementing TB diagnostics, the same platforms could test women's viral loads for HIV or or their newborns for HIV as well, and it was an interesting conversation from between national programs on how they will share those, and it was not a straightforward one. So I think also as donors and partners, we have that responsibility of not ourselves creating through our financing streams some of those verticalities that, especially in the cervical cancer, again, has helped us now manage to actually achieve some of the program growth, because currently, except for our maybe funding for general population, most of the funding goes only to women living with HIV, because it's only PEPFAR and Global Fund that actually fund some of the secondary prevention. So the need is great, and it's just basically we cannot afford being vertical. And most of the approaches that we do, if not all, are integrated, and that has become just a norm, not even an option. Thank you.
Maybe if I can quickly add to that, I think for us it's very important to work with local organizations more than, you know, coming with some fundings and just throw them from the top, so that they could really own and lead the work that we are funding. So I think that's an important thing to align also, you know, to primary healthcare delivery, and in our case, but the delivery of important vaccines.
Thanks, Valentina. I don't see any. Do you have anyone else has any questions? Like, I don't see any questions in the chat. But if not, I'll hand it over to Taryn, because we're almost at time to give some closing remarks and summarize what we heard today. It's going to be a hard task, so I don't envy her. So over to you, Taryn.
Thanks, everyone. Hi, I'm Taryn Russell. I'm the acting executive director at Results Canada. This is one of those topics that always infuriates me, because just the inequities are so stark, and you know the stats and then you hear them again, and I just get more rage-filled, both as like a health advocate, as a woman, and just as a human. But I thought this conversation was fantastic, because as I was taking notes and thinking about how I'm going to reflect, it was comforting to know that there's so many smart, competent people, organizations, and governments that are prioritizing women's health, and that are trying to catch up to the centuries of exclusion of both women as health actors and practitioners, as women's issues in terms of research and development, and really thinking of what are the solutions and how can we make progress in these issues. So I feel like I started really rage-filled, and now I'm ending optimistic, and love to hear the strong recommendations from everybody on the panel on what we can do, and especially what the Canadian government can do, we as advocates, and within our organizations. And so some of the topics that just stuck out to me as we were going through, one of them was just, this sounds obvious, but women have broad needs, and they are more than just sexual reproductive health and rights. And they also are more than just a certain age group. Women are not a monolith. We come from different countries. We are in different age groups. And so when we look at women's health, we need to be thinking of that in terms of how we're tackling it. So I thought, you know, the example around, we are so close to eliminating cervical cancer, but to do that, we really do need to look at women across the spectrum of ages and treatment and prevention. So that aspect of it, in terms of thinking of women's health more broadly, was an important one. The other one, of course, is just we need to be really looking at how we can effectively engage with communities across the world, and where they are most impacted by these health issues, especially and the global south, and how to do that. I think the comments around community engagement, and just recognizing that that is not necessarily an easy thing to do, good community engagement, and that we need increased funding to be able to do that. We need increased flexible funding and long-term funding and expertise in how to do that effectively. So I think that really came across, and that's going to be one of those things that if we can get right and do a little bit better, we'll make a lot more progress across these areas. I think the other aspect of that is just really leaning on the expertise of people in countries, and how can we more effectively make those collaborations and work with experts across different countries and different issue areas. The other thing that really came out too is, of course, as an advocate, that's my frame of mind, but turning more people on to advocacy for women's health, getting more women excited about careers in women's health, and becoming invested in science, and how can we do a better job at that as well. And then I think the strong thing that came out to me as well, and I think Robin said this too and others, is just to give Canada some recognition and really doing a good leadership role in this area, and how important it is to be vocal in these spaces, to be encouraging other governments, to be making sure that where Canada is funding and devoting its resources are also aligned with this agenda. Obviously, as advocates, we always want to see more funding going to these areas, particularly to help close the gap. But I think that came across strong, and that leads to kind of our role as advocates. How can we ensure that the Canadian government continues to prioritize this, and that we can push them to continue to kind of collaborate, invest in partnerships with organizations like the ones on the panel that are going to show results in this area. So that's kind of my very high level 3-minute summary of a really engaging conversation, of which I took many notes and excited to follow up on a lot of those pieces. I did want to do a plug before we left in kind of in the aspect of trying to push forward more information and more analysis in these areas. Results Canada and Lee Wraithby, who's on the call, recently co-authored a report on investing in innovation and equitable access to end the tuberculosis epidemic, which I think is very related to some of the conversations on this call. And I'm sure somebody will throw a link in the chat if you haven't had a chance to look at that. But we're excited to, you know, continue to collaborate with your organization on future ways that we can raise these issues and provide the information that decision makers need to continue to kind of make good investments here. And with that, I just want a huge thank you to everybody, for all our panelists, for spending the time today and joining us and sharing their expertise. Big thank you to AICTA and the team who put a lot of work into organizing this event. Thank you to Global Affairs Canada colleagues, and thank you to Dr. Tanguay for joining us as well. Your interventions were really appreciated. And then just again, thank you to everybody for joining, and I hope you got a lot out of the conversation. And we'll all chat again soon. So thanks so much.
Thank you.
Thank you. Bye.